Hello, today we're talking about acute coronary syndromes. Acute coronary syndromes include unstable angina and STEMI and STEMI. In unstable angina, there's a change in character of the chest pain, the change in frequency or a change in duration. There are EKG changes, but there's no troponin changes or no troponin elevation. In NSTEMI, it has all the features of unstable angina along with positive troponin or a new wall motion abnormality. In STEMI, the characteristic ST changes that characterize the STEMI, which is ST elevation. Basically, heart attack is the leading cause of death, and today we're going to crack the killer's code. Myocardial infarction is defined really as death of heart muscle or necrosis because of blockage of one of the coronary arteries. Now, in the past, it wasn't sure why people developed coronary disease. In the early 1900s, a scientist fed rabbits animal protein and then cholesterol to prove that the cholesterol plaque in the arteries came from eating cholesterol. This led to the lipid hypothesis. Even though this explained why people develop plaques, the reason why some people developed a heart attack, whereas others had a stable plaque for years, if not decades, wasn't very clear. Dewood and et al. Did coronary angiograms on patients having heart attacks. Within the first few hours of a heart attack, 87% of the patients were found to have a thrombus. Therefore, the thrombus theory of myocardial infarction was born. Subsequent work on the pathology of the plaque showed that there is a vulnerable plaque where there's a lot of lipids in the plaque and a thin wall. When the thin wall ruptures, the interior of the plaque is exposed, leading to clot formation and the heart attack. On the basis of this, the ISIS trials were conducted. The initial ISIS trial, basic idea was to use a lot of patients with simple protocols so that they could be applied in any hospital. The first trial proved beta blockers were beneficial, and it was a randomized trial. The second trial involved use of aspirin and streptokinase. This showed that using aspirin gave a 23% drop in mortality, and using aspirin and streptokinase together caused a 42% drop in the primary endpoint, which was a huge finding. Subsequently, it became clear that time is muscle and you should treat quickly. The time of onset to symptoms, to presentation, to administration of a lytic should be ideally under 30 minutes. This subsequently was complicated with bleeding, including intracranial hemorrhage, which was fatal. Therefore, a new idea was born, spearheaded by a team in Beaumont Hospital. Here, they assessed whether taking the patient straight to the cath lab and opening the artery with an angioplasty and a stent is superior to using lytics. So patients were randomized to one of these two treatments. At the end of 2 years, 27.2% of the patients who underwent primary angioplasty needed a repeat procedure, whereas 46.5% of those who got lytics needed a repeat procedure. Therefore, it was pretty clear that the combined endpoint was reduced by primary angioplasty in a way superior fashion compared to lytics, and this became the standard of care. Going back to our original triad of unstable angina, NSTEMI and STEMI. In STEMI, it's pretty clear time is of the essence. In NSTEMI, when there's unstable NSTEMI, as manifested by ongoing symptoms, cardiogenic shock, heart failure, ventricular tachycardia, urgent cath and intervention is preferred. Unstable angina has many mechanisms, including plaque rupture, vasospasm, hemorrhage into the plaque, or increased demand, and addressing these issues is essential. Thank you for watching.